So this is my case study on the presentation on applied practitioner role by George Kirkman. So we'll get straight on with it. Our case study is a 38-year-old male. He's got a busy family life with 2 children and a wife. He's a keen cyclist competing in ultra-endurance cycling competitions. Currently in training for a 3,000-mile race across America, which is upcoming in about 3 months. So he's currently training for that, doing big miles at the moment. He currently works full-time as a hairdresser, running his own hairdressing company and working 30-hour weeks. So as you can imagine, that involves a lot of standing up, a lot of repetitive motion at the arms and hands, using similar techniques every day. Like we say, he's a keen cyclist. He is a very ambitious cyclist with big ambitions, and this shows in the number of miles the cyclists compete in a week, cycling around 250 to 400 miles a week whilst maintaining a full-time job. A bit about bike position. Improper body position could attribute to several overuse ailments with the repetitive motion of cycling. Small adjustments, particularly at the body interface with the bicycle, can affect the rider's biomechanics throughout the kinetic chain, improving comfort, efficiency, and power generation. Prevention, knowing the common mechanisms for traumatic and overuse injuries, and early correction of strength and flexibility imbalances, technique errors, and improper bike position are imperative to avoid an injury on the bicycle. Okay, so we'll move on. Work, family life. Patient works 30 hours a week, as already mentioned, as a hairdresser. So this involves a lot of repetitive movement and being on his feet. He also has a young family with 2 children and a wife. This means he has a very busy family/work/family/training balance, allowing him less time for recovery. Obviously, this can affect his sleep. He's got a very young baby at the moment, so this is affecting his sleep with night feeds and things like that, which is affecting his recovery and is going to have to be taken into consideration as a possible yellow flag when doing the treatment. As we say, he's got a very busy family life, lifestyle, so it's imperative to keep that in mind. And that obviously is something to note during the subjectives. It all contribute and affect his injury problems as well as affect recovery. Okay, we'll move on to presenting conditions. The subject is a right-handed 38-year-old Caucasian man. Yeah, the subject is a right-handed 38-year-old Caucasian man referred to an outpatient sport-focused physical therapy clinic. He has had a medical diagnosis as cervical disc disease and has been referred to us for treatment. Again, he's a road cyclist, approximately cycling 150 to 250 miles a week. The subject has consented to physical therapy treatment. He presented to us with a chronic history of right cervicothoracic paraspinal pain, right parascapular pain, and associated muscle tightness in these regions. These complaints had intensified approximately 4 weeks prior to an unremarkable 150-mile bike ride. In addition to this, an exacerbation of he's had an exacerbation of these pre-existing symptoms. So we'll move on to the 6th slide. The patient has also complained of a concurrent novel onset of right hand numbness on the dorsal and palmar surfaces of his right 5th digit and medial 1/2 of his right 4th digit. The subject described these distal symptoms as constant and unchanging, regardless of the activity or position, and unaccompanied by pain. Additionally, it complained of intermittent self-described zings at the posteromedial aspect of his right elbow, which occurred occasionally while sneezing, but otherwise was unrelated to that activity and not reproducible, despite many attempts on his account. So that's what he's been presenting with. So we moved on to the subjective, to do the subjective findings. During the subjective, in the early parts, the patient delved into how worried he was about the treatment. This is a potential yellow flag as it can affect treatment time. Obviously, having worry and being anxious about treatments can have a big effect and big impact on the treatment time. So this is something we need to take care of, and this is something that is a yellow flag. A study conducted by Taylor found, unfortunately, some athletes do not return to their previous levels of performance post-rehabilitation. This can be due to psychological barriers that developed not only because of the injury, but also of the lack of physiological rehabilitation that greatly impacts performance. So again, this is just something we need to take care of in the subjective findings and make sure that that we take care of the patient's worries about his job and things like that it could affect. The patient's primary problem involved right upper extremity pain, paresthesia, and weakness, which were affecting his activity of daily living, job duties, and athletic participation. Information gathered during the history and systems review led to a differential diagnosis of cervical nerve root radiculopathy versus distal ulnar nerve involvement. Understanding the differential diagnosis of these conditions is essential in identifying the best treatment options and plan of care. This is particularly important with at-risk populations for cervical radiculopathy and or peripheral neuropathy, such as hairdressers and cyclists. Obviously, with the repetitive movements and with a lot of vibrations and things in road and continual sustained posture, cycling can be a risk for cervical radiculopathy, same as being a hairdresser because of the repetitive movements and constant strain on that sort of thing. Anyway, so we moved on with the subjective findings. We moved on with the special questions, red flags and yellow flags. Special questions included general health, drugs, steroids, anticoagulants, recent unexplained weight loss, rheumatoid arthritis, spinal cord symptoms, dizziness, and recent investigations were all asked to the patient. He replied no to all these, except that he has had a previous X-ray that had previously been done, but there was no serious concern, and the patient had been referred for sports therapy due to the X-ray results. So that was something we needed to make sure of, but the patient said it was fine. Red flag questions were also asked and noted throughout the subjective, of which none appeared. There was also no mention of previous trauma. There was a yellow flag present during the subjective, which was when the patient mentioned that he was anxious due to the possible effect on his job. This was something to be aware of during the treatment. Obviously, the job was the most important thing for the patient. He was obviously a keen cyclist, which was impacting him, but the main thing was his job. With a young family and kids, his most important thing is his income, and he was scared that if he wasn't able to do his job, of the implications that may come from this. Due to the answers throughout this section, we decided it would be okay to continue on with the objective assessment. Okay, so objective findings. The first stage of the objective, due to the findings in the subjective, was a postural check. So this is the first stage of the of the objective. Upon observation, the patient presented with increased kyphosis in the upper and mid-thoracic spine, as well as a forward head posture. Systematic sport training may generate specific spinal adaptations depending on the posture sustained during training. Cycling is specifically vulnerable to this due to the sustained posture on the bike for periods of long time. As we've mentioned this, as it says, systematic sport training may generate specific spinal adaptations depending on the posture. So cyclists who are cycling long distance for long amounts of time, their posture may change, which can lead to kyphosis in cyclists, which is quite common in cyclists who do a lot of cycling and do long distance. This is the body's way of getting used to that position and adjusting it, but obviously can also lead to detrimental and negative effects. And obviously cycling is a big risk factor for kyphosis, but due to the sustained posture, especially for cyclists like this cyclist who is focusing on 3,000, who is training for a 3,000 mile bike ride, is going to be putting in a lot of miles a week, which is going to make this obviously have a big effect. Anyway, moving on. After the postural check, we moved on to clearing tests, as this is an important part of the objective. We did various clearing tests to which there were no positive tests, such as VBI testing, CN testing, as well as other ligament tests, of which all came back negative. However, during the Sperling's neck compression test used to assess nerve root pain, there was a positive test. A positive Sperling's test is when the pain arising in the neck radiates in the direction of the corresponding dermatome ipsilaterally. The positive test also gave the clinical impression of nerve root radiculopathy. So again, we did various tests, of which all came back negative. However, the Sperling's test came back positive. This again led our decision to believe this possibly could be nerve root radiculopathy, which the patient is suffering from. We'll go back. There is some risk factors for cervical radiculopathy, and some of these factors may increase the risk of developing cervical radiculopathy. These are things such as age. The risk for cervical radiculopathy tends to increase with age. Some estimates state that the risk peaks in a person between 40 and 50. Our cyclist is age 30 now, so is now becoming close to this at-risk age. So obviously with him being 38, is getting close to between the 40 and 50 age, which is most at risk for for cervical radiculopathy. Strenuous activities are also capable of putting high levels of that are capable of putting high levels of stress on the cervical spine, such as cycling and weightlifting, as well as repetitive neck motions or vibrations, such as cycling without vibrating equipment, or repeated diving headfirst from a diving board into a pool is also a risk factor for cervicular radiculopathy. So again, our cyclist and our patient is ticking a lot of these boxes. Is doing a strenuous activity for long amounts of time, which is causing repetitive vibrations and sustained posture, which is obviously increasing the risk factor for cervicular radiculopathy. Anyway, we'll move on to further objective findings. During our continued objective examination, there was decreased active end of range motion with cervical flexion and right cervical rotation. During cervical flexion, the subject was actually unable to touch his chin to his chest. However, this action was not affected, nor did it elicit pain. So during the range of motion testing, he was not performing well with cervical flexion, as well as right cervical rotation, even to the point he was not able to push his chin down to his chest. This was likely affected by this chronic history of right cervicothoracic paraspinal pain, right parascapular pain, and associated muscle tightness in these regions. The muscle tightness was likely leading to a decreased range of motion despite not eliciting pain. However, active shoulder and elbow range of motion were within normal limits, and overpressures were performed in all planes of range of motion in which were not affected. And also, obviously, the ones that were affected, we would not do. The ones that were affected would not do overpressures, as this could severely affect the objective and cause more harm. Further examination revealed mild fascial restrictions that were palpable, so we could feel these. Palpation also revealed mild atrophy at the base of the fifth digit as opposed to the left. So there was mild atrophy on his base of his right fifth digit, as opposed to his left hand, which was none. This would be likely due to the concurrent right hand numbness and issues with the fourth and fifth digit on the patient's right hand. Okay, we'll move on to more objective findings. We moved on to examination of sensation. This indicated decreased sensation of touch at the dorsal and palmar surfaces of the right fifth digit and the medial part of the fourth digit, which would be in line with the investigations that we've already done with the issues with his right hand. Right upper extremity remained normal during dermatome and myotome testing. Strength testing of the cervical spine and shoulder demonstrate no issues with a 5 out of 5 testing, which is how we grade the strength testing, and that was a 5 out of 5, so that was no issues. However, strength testing of the right hand intrinsic muscles indicated decreased strength during abduction and adduction of the fourth and fifth digit in lines with previous tests. These were rated 3/5 on the strength test. This is likely due to the concurrent issues and weakness with the fourth and fifth digit. Okay, we're going to move on to clinical to contraindications now. As the clinical impression of the patient was likely to be cervical nerve root radiculopathy, doing any extensive range of motion as well as overpressures at the cervical spine should not be done. This is due to the pain that he was already in, due to the effect that he was already in with range of motion. We would not move on to any overpressure or anything like that. This is obviously, like I said, due to the current restrictions during cervical flexion. Doing overpressures could make this worse and result in a decline in the condition, and that's not what we want to do. Due to the decreased strength in the adduction and adduction of the fourth and fifth digit, strength tests should be done with caution. However, as these may cause improvement of the symptoms, they should be allowed to perform. So again, these should be taken with caution. However, if it is deemed that they are more, they're going to be more positive than negative, then we'll continue to do these. But like I say, keep an eye on the condition and stuff whilst doing these. Okay, we're going to move on to the category. As a result of the subjective and objective tests, I would categorise this patient as right upper extremity pain, paresthesia, and weakness, which were affecting his daily living, job duties, and athletic participation. The patient would also be categorised as having radicular neck pain and weakness and numbness in right hand intrinsic muscles of the fourth and fifth digit. What is grade 3 of neck pain? Neck pain with neurological signs or symptoms. Complaints of neck pain associated with significant neurological signs, e.g. decreased deep tendon reflexes, weakness, sensory defects. These complaints suggest malfunction of spinal nerves or the spinal cord. This requires closer monitoring to detect any progression of neurological signs and should be followed up by physios or trained sports therapists. Again, as we've already mentioned. Okay, so we're done with the objective findings. We're going to move on to our treatment plan now. There's some basic exercises that the patient will be prescribed. Initial intervention treatments would primarily target symmetrical cervicothoracic pain and joint soft tissue mobility for improved function. The goal of this will be to reduce cervicothoracic pain and hand symptoms. This will be performed using manual mobilization techniques, including side glide techniques at the grade 3 on C3 to C6 and manual cervical distraction. A study by Briggs in 2018 found that utilizing manual mobilization techniques during treatment reported an improvement in periscapular discomfort. Basic exercises were also given to the patient to focus on mobility and flexibility, as studies have shown that this can help reduce the risk of cervical radiculopathy. These are some of the exercises, basic exercises that the patient will be prescribed in the early stages of treatment. So we've got cervical retraction, as you can see on the top left, cervical extension, as you can see on the top right, deep cervical flexor strengthening, which you see on the bottom left, and scapular strengthening, which you can see on the bottom right. Again, these are prescribed early, as these are basic exercises that can be done pretty much at any stage of recovery. Obviously, these elicited pain or discomfort that was severe or even restricting. We would tell the patient to not do this until they could do it without any pain. Again, these are basic exercises that will be prescribed during the early stage. The focus on these exercises is to assist with cervical extension and retraction, helping increase mobility and flexibility, which will help speed up treatment. Cervical flexor and scapular strengthening have also been included to help with strengthening the weakened muscles and leading to a quicker recovery. These exercises have evidence in helping recovery from cervical radiculopathy, and that's from Young et al. 2009. These exercises should be performed and completed daily at home. I made sure not to overload the patient with too many exercises. This could lead to worsening symptoms and also discourage the patient from carrying out the exercises. Again, at the early stages, you want to do simple exercises that the patient will remember. If you overload the exercises, the patient is less likely to do them and less likely to keep up with them. Whereas if you give them simple exercises that can be done daily at home, it makes it easier for the patient to follow them. Okay, moving on. Soft tissue mobilizations were also performed on the cervical paraspinals, upper traps, and rhomboids, using techniques involving deep pressure myofascial trigger point release. Due to the growing evidence, soft tissue mobilizations were included in the treatment plan. During the early stages of rehabilitation, the patient was also educated on postural control and awareness, emphasizing on positioning, as the subject noted an increase of symptoms on days when he was working long hours. So again, when the subject was working long hours at a hairdresser, doing repetitive movements, this was making his condition worse. So the subject was noted about postural control and ways into which to decrease this while at work, because obviously this is the main issue with him having to earn money and working long hours during the treatment process. Again, this was to help with the posture whilst at work and reduce the increase in symptoms when working long hours. This was also incorporated into a multimodal treatment approach. Okay, we're going to move on to treatment still. As the treatment continued, the patient was educated on postural control and awareness with emphasis on positioning. This was done as to improve in bite position and posture would lead to a decrease of the chance of reoccurring injuries in the future. Obviously, educating this patient and working with him on bite position is going to prevent this from happening in the future, which is a positive and obviously something we want to encourage. And it's going to help him with problems now. He's going to continue the cycling while he's being treated and in the early stages of rehab and obviously during the mid and late stages. So this is something we wanted to work on straight away, which is something that was going to help along the way. Kennedy, in a study in 2008, found that the position while cycling, as well as the cyclist's focus on posture, plays a significant impact in injury and re-injury rates. Again, so this is something that was backed up by many studies that we found, that focusing on the bike position and giving the cyclist a focus on posture plays a big part in the recovery. The patient participated in a static bike fitting assessment by the primary treating physical therapist. This was conducted in order to evaluate his positioning on the bike to potentially decrease stress on the right ulnar nerve and address any faulty posture which may have contributed to his injury, prevent further injury and improve performance. Therefore, a big focus was put on position to reduce symptoms with a focus on return to sport. Basic exercises were also implemented at this point, as these help reduce the risk of cervical radiculopathy and help improve symptoms. Okay, we're going to move on to slide 20. So again, as this treatment progressed towards the later stages, we focused on advanced exercises to continue the progression. These were going to be focused more on the athlete soon returning to cycling properly, so I wanted to do some functional exercises that could go towards that. The later visits focused primarily on periscapular exercises to promote optimal posture control and muscular endurance for cycling, and to help with hand issues whilst hairdressing. Again, so we were focusing on his job as well as the cycling to incorporate these into movements that he's going to be doing at his work, so they would obviously have a good effect. Prone bilateral upper extremity extension and abduction were initially prescribed based on his periscapular results, and posture was observed and corrected if needed. The dosage and prescription of these interventions was focused on performance until fatigue or the loss of appropriate technique was demonstrated. So many of these positions, such as the top left and bottom left, these were performed until the athlete was either losing focus or losing performance or fatiguing, and then they would stop them, and then we would repeat these over so many days based on how he was doing to start with. Verbal, visual and tactile cueing were used to promote appropriate technique as needed. Once the patient was able to demonstrate appropriate endurance and control neuromuscular re-education, progress through the use of increasing unstable surfaces and resisted neuromuscular control exercises to facilitate improved dynamic control and endurance. So again, we up these with using unstable surfaces and adding extra things in to make these harder as the patient got better. Finally, education was focused on improving the subject's awareness of his cervical, thoracic and upper extremity positions in order to minimise sustained forward head posture, limit shoulder protraction and optimise hand position throughout long rides. This was done to educate the patient on ways to reduce the risk of further re-injury and aid in the prevention of injury. So again, these are ways that we were going to focus on his posture and the positions he was in to limit certain things happening and re-happening, which could cause re-injury or obviously contribute to this injury in the first place, and educate the patient on ways to reduce this. So slide 21 is the conclusion, which we'll move on to now. Overall, the patient during treatment has received mobilizations, soft tissue work, manipulations, exercise, refitting and bike position knowledge and education of posture and positioning. This is during the treatment. Obviously, this is one of the big points he wants to emphasise, the work on positioning of his bike for future prevention of injury and re-injury, and obviously during the later stages of injury when he's back on his bike, working on them, making sure the cyclist takes note of his position and the positions that he's putting himself in to prevent the risk of re-injury and obviously the injuries he was currently suffering. Research has found that several treatments combined has the best outcome in regards to cervical radiculopathy, and this was by Boyles in 2011. So again, research has backed up our thing that several treatments which we used and combined will be the best outcome for the patient to recover fully from the treatments. That is why we use several different treatments, as we believed a mixture of treatments will work in the best interest of both the athlete and the people treating him. The subject was advised to have visits monthly for soft tissue work to help with recovery and prevention, as this is something that he reported on during the treatment plan that was really helping him, getting soft tissue work and mobilizations. So he was advised, if that was working and helping him, to keep coming every 2 weeks to every month to have these go on during obviously his rehabilitation and injuries in the future, and to avoid any injuries. Exercises, again, we're told to be kept up to help with future prevention as well as assist in stability and strength. So obviously we don't want any further injuries. So in order to do that, a lot of strength exercises and exercises that we're done, we're told to keep up to prevent him from further re-injury. So that's my video finished. Sorry for the poor filming, but obviously I've not had any access to equipment and I'm in my bedroom. So anyway, here's the references. I've got 2 slides of references. Hope you enjoyed the video, and thank you very much, and see you later.